Hello, GP learners, and welcome to this stream where we're going to be talking about what is the GPC. And to kind of help demystify that, I thought I'd bring on an expert, because I'm not that, and they're going to talk about basically what the GPC is, how is that different to the BMA, the LMC, and various other organisations, and basically answer all the questions that we've had. And I'm really proud and honoured to introduce Dr Katie Bramall-Stainer. How are you doing there, Katie?
Hey, Hussein, nice to be here. Thank you for inviting me.
And thank you for joining us. And for those that don't know, Katie is an absolutely amazing person who, to be honest, has done some cool stuff. I'm going to let her introduce herself properly. But if you haven't seen her talks at the LMC conference, I highly recommend doing them. They are possibly some of the most stirring and stimulating speeches ever. Anyway, Go for it, Katie.
No pressure, right? So my name's Katie. I'm a GP. I practice in Hoddesdon in Hertfordshire, but I'm also the Chief Executive of Cambridgeshire Local Medical Committee. That's in LMC. And I'm the Deputy Chair of the UK Conference of LMCs. And that's pretty much like the GP conference of the BMA, which is the British Medical Association. And the BMA's got lots of different committees, from students to retired members. And I sit on the GP committee, the GPC. And I also sit on BMA Council as well, representing students, doctors and retired members across the east of England. So I hope you can see my screen okay. I thought I'd start with a fairly apposite GIF, which is doing the rounds on meme generators this week around the ship that got blocked in the Suez Canal. And I think when you start off in general practice, it can feel a bit like you're totally bombarded by these three-letter acronyms everywhere around you, and they just seem meaningless, and people churn them out constantly as if it's an episode of Line of Duty, and everyone seems to know what they mean, and it can be quite puzzling as to where everything sits. So I was going to try and demystify a lot of that today. So if I start with the GPC is the General Practitioners Committee. It's a UK branch of practice committee, part of the British Medical Association, and it's the only body that represents all GPs across the UK, irrespective of your contractual status, from trainees, sessional GPs, out of hours, prison doctors, partners, salaried, you name it. It deals with all matters affecting NHS GPs, whether they're BMA members or not. And it's the only body that has got the right to negotiate with the UK government around putting in place a national contract. Now, that is divided into GPC England, GPC Northern Ireland, GPC Scotland and GPC Wales. There are also two what are known as task-oriented subcommittees that are semi-autonomous, which is the sessional GPC that is chaired by that handsome chap on your screen there. That's Ben Molyneux. Ben is a GP in East London and has been chairing the sessionals for a short while now. And that lovely lady with a lovely summer background is Lynn Horofsky, and she is the chair of the UK GP Trainees Committee. And they have, both of these committees have got roles and representatives from across the UK, and they again have a delegated authority mandated to work and negotiate with the UK government around contracts for trainees and contracts for locums and salaried doctors and so on. And they're particularly helpful, especially the sessional GPC, around pension issues that affect sessional GPs, say, rather than partners. So they're really important. And here, in this amazing championing of diversity, you can see some of our colleagues who are the chairs of the devolved nation GPCs. So down in the corner, you've got Richard Vaughtry, a GP in Leeds. He is the chair of GPC England. And up at the top, with his stethoscope round his neck, is Alan Stout. He is the chair of Northern Ireland GPC. And the very business-like chap with his suit and tie is Andrew Buist. He is the chair of Scotland's GPC. And the chap with the beard in the corner, that is Phil. He is the chair of GPC Wales. And they deal with all of their issues in those devolved nations with those devolved governments. So we've covered the GP trainees, the sessionals, and the different 4 nations. Now, the BMA itself is both a trade union and a professional membership organisation. So it's covered by trade union law in the way that other organisations are not. So only the BMA can seek out collective action or a mandate for industrial action, such as the junior doctor strikes. So the BMA is pretty much a range of representative committees, but also scientific committees, such as the Board of Science, the Board of Ethics, and so on. And it's recognised by NHS employers as the sole contract negotiator for doctors. And the BMA's aim is to promote the medical and the allied sciences and to maintain the honour and the interests of the medical profession. So there are lots of other organisations that will purport to speak on behalf of a group of doctors or GPs or whatever, but actually it's only the BMA that has the trade union status conferred upon it. And that's important when it comes to if things get legal. For example, if you're a GP employed on a contract with a practice, it's probably a good idea for you to be a member of the BMA because you get access to that level of protection around employment matters. So moving on a bit, here we've got a screen of various pictures, and what these images are meant to represent is all the different parts of the GPC, because the GPC has its main business, but it also has a number of policy groups where a small subset of members focus their time on particular areas. So if we look over on the left, we've got finance and premises, and we've got clinical and prescribing, that group leads on matters relating to drugs, prescribing, vaccinations and immunisations, and all how that feeds into QOF and the main contract, and will take on separate issues that perhaps aren't in the main contract, but around which there'll be lots of discussions. So at the moment, I think prescribing and responsibility around transgender patients is something that we really want to try and find a solution for across the whole country, and avoiding the postcode lottery that exists at the moment. There's also commissioning and provider development policy group, and that relates to matters related to commissioning and the provision of services, including that of CCGs, and practice-based commissioning, and enhanced services, out of hours, new providers, and all of those businesses around the internal market. And that's taken quite a lead around PCNs and so on, which of course is another TLA that we'll be covering a little bit later in the talk. You can see in the top in the middle a black and white old-fashioned bit of paper there, and that's my area, which is contracts and regulation. And contracts and regulation policy group leads on regulatory and contractual issues relating to GPs working within the NHS. So our remit covers things such as CQC, the performers list regulations, the GMS contract, the PMS contract, and the APMS contract. National bolt-ons, which are called DESs, Direct Enhanced Service, such as the Special Allocation Scheme that used to be called the Violent Patients DES, or the Flu DES, or the PCN DES. So you can see there's quite a bit of crossover, and it might also deal with contracts and interfaces around private practice and around, for example, prison doctors too. So it's quite a wide remit. And then you've also got education, training, and workforce, and that is a big policy group that also has membership within it from actually. All of the policy groups have membership within them from sessional GPC and from the GP trainees subcommittee. But education, training and workforce leads all around recruitment and retention. And where the allied members of the primary care team fit in, they have some business to do with that as well. So that's kind of a new part of it. IT is another policy group So you've got the Information Management Technology and Information Governance Group. So that very much is around not just digital, but also data. And I think with the oncoming shared care record, you can see how those two things merge together. And so the IT group leads on all issues pertaining to GP information management, all details around good governance, the interface between primary and secondary care, all the training requirements with regards to IT and that change management. And my goodness, over the past 12 months, haven't we seen that come to fruition? And as I said, there's premises and practice finance, and premises and practice finance groups, they lead on finances and resource issues that relate to practices as businesses and GP specific payments such as pensions, tax, accountancy, premises and geography related costs. There are also regulations around practice premises and how they get funded, and the premises cost directions is a very big piece of work that is being presently finalised with the government and is waiting for publication, but that has been like several years in the negotiations. And finally is representation. And representation is slightly different to the other policy groups because its chair is directly elected from the rest of GPC rather than being kind of a voluntary or appointment post. And it's really important representation. Representation is like the good housekeeping guide of GPC. It works to ensure there's adequate representation of all GPs, both on GPC and also within the wider NHS. So when I, myself and Zoe Norris raised our concerns and whistle blew around the issue of sexism. It's very much representation that's taken that brief forwards, that is trying to implement the Romney recommendations, has just appointed a gender diversity champion, who's Rachel Alley, who's an LMC secretary and a GP partner in Plymouth. And she's also taking on board the incredibly important role around ensuring there's adequate diversity from across all ethnicities on the committee as well. So there's a lot of work to do there. There's a lot of work to do, and there's a lot of change still to come. And what I will say about things such as, you know, the college, the BMA, GPC, they're not areas where you get quick changes. They're areas where things happen slowly. But so long as you're on the right direction of travel, we'll get there. But it can be quite difficult in itself for those of us who are a bit less patient than others to try and see those changes established. It does require a little bit of force to start to get them through. But I think it's really important because, you know, if GPC isn't seen to be representing the workforce out there, well, then its currency is going to be diminished in the eyes of the government that they're negotiating with. So it's in the interest of the BMA and in the interest of GPC to reflect the workforce it represents, because I'm not going to pretend that, you know, I can speak the truth of a colleague in their 50s and 60s who came to the UK maybe in the 80s or 70s and who's experienced, you know, very different receptions from people and how the NHS has treated them. I could never possibly speak for them in the same way I wouldn't expect someone to be able to speak for me and my experiences. So I think that's incredibly important. Okay. And as you can see in the middle, we liaise really closely with the college, and the trainees committee liaises really closely with the AIT committee of the college as well. So that is a bit of a whistle-stop tour around how GPC works and so on. So if we move on, I want to focus on GPDF. Now, GPDF is the GP Defence Force, which is quite a military term if you think about it. Now, their byline tells you a bit more, which is listening, supporting and influencing. And this is the point where maybe just a little bit of a history lesson might be helpful. So if we go right way back before 1948, when the NHS was founded, way back to the start of the 20th century, under David Lloyd George, who was the last Liberal Prime Minister we had, he put in place in 1911 the National Insurance Act. And the National Insurance Act, and of course he's the name of the Lloyd George envelopes that we have and that we're now, digitalising. So the National Insurance Act led in part to the formation of local medical committees. And this was when GPs in an area, there was no NHS. Everything was done privately or for free or under patronage of the local landowner who would give you enough money to keep going, and you wouldn't charge people who are in penury and so on. But it was all a bit chaotic. And so LMCs came together to kind of set prices, to set standards, to be clear in terms of the local profession and how it operated. And it was very much on the kitchen table of one of the local GPs for a given area, and they'd probably meet over a pipe and a wine in their house or whatever, who knows what, back in 1911. And they started to, give a little bit of their earnings to help supplement this local medical committee to do its job. And then nationally, all of those LMCs together would put a little bit of that money into a pot to help look after, support and defend general practice, because general practice as a branch of the medical profession was not in the BMA. The BMA was very much seen as a hospital consultants association, nothing like how it is now. And as time progressed and as the NHS came into being, the argument for the BMA became much stronger to want to be a pan-professional trade union and organisation. And the one thing that didn't fit was the fact that GPs were on the outside. And so part of the negotiations to bring GPs into the BMA was to ensure that they were going to be catered for appropriately. So the students have a certain amount of funding that goes into their branch of practice committee, as do the consultants, as do the juniors, as do the staff and associate specialists, and there's retired members, private practice, armed forces, you name it. But GPs, as we know, are very, very different. It is not simply a secretariat that looks at your national contract and bits around it and your pension. We have endless different contracts. We have a whole different regulations around how we practice, around the performers list. We have our own regulations around dispensing, around estates. It's a complete mini industry and business in and of itself. And so therefore, the GP element of the BMA needs to be much bigger and have a lot more staff working a lot harder in all of those different areas that we've touched on: the clinical and prescribing, the premises and the finance, the commissioning and service development, the contracts, the regulation, and so on. So that is topped up. So the money that goes in from the BMA coffers is our share of GP, and the amount of money extra that's needed to do the job properly comes from the GPDF. And LMCs, local medical committees, are still in existence. And we have, we've overseen so many restructures and changes in the NHS. And we're always told, it's the end as we know it. And one of the most key things I learned as a trainee under Lawrence Buckman, who was the GPC chair at the start of the 21st century, was very much around they're always saying this, and it never is. And I always tend to say that GPs are a bit like the cockroaches of the NHS. Come the nuclear apocalypse, come endless restructuring, still going to be GPs. We're still going to be there seeing our patients and getting the job done. And we're still going to need a body to, collectively negotiate on our behalf locally. Because you've got your national contract, but you've also got local contracts as well, which are called enhanced services, and they're like a bolt-on to the contract. And so a local enhanced service is what you'll see written as a LES or an LES. And there's discretionary funds that a local CCG, that's a clinical commissioning group, will be spending on its practices. And there's also monies that have come from historic GP contract reviews that will probably run into the millions in a given area. And there's rules attached to those monies about how they're commissioned in terms of their outcomes for that population. And that's what is negotiated with the LMC. And the LMC functions by charging a levy from its practices. And the levy is enshrined in the GMS Act. And it's a certain amount of pence per patient. And it depends how much it is, depends on which LMC you're in and how much of a complex organisation they are. Some of them are quite hands-off and it's quite a small levy. Some of them get very involved and do lots of other things to their practice, and it's quite a big levy. It's horses for courses, really. But 5% of an LMC's levy still goes into the GPDF. And so we're still funding that extra bolt-on that helps prop up the GPC support structures to be able for the BMA to provide what is needed for GPs as businesses and as practitioners. So if we look on this slide, we've got lots of different logos of LMCs from across the United Kingdom. And as I say, we've been around, over a century, and there's a lot of knowledge in LMCs. There's people who have, lived through and experienced a lot of changes and have a genuine understanding of the local healthcare environment that perhaps new people in a CCG aren't really privy to. And of course, we're moving away from CCGs into integrated care systems next year and having integrated commissioning plans locally in a place level. So everything's all a little bit up for grabs at the moment. So the strength, I guess, of the LMC, and I'm having these conversations locally within Cambridgeshire and Peterborough, is I'm not going to want funding for a seat, and I'm not even going to want to vote at a table. I just want to be there as an observer. Because then I have the influence, I have the knowledge, I have sight of the papers, I can help bridge those conversations and help share the understanding about how things will land at a practice or a PCN or a place level. And it's that lack of conflict of interest that is really strong. And that's all underpinned by the fact that LMCs are bodies in statute, named in successive NHS acts. So we're not really going anywhere soon. I mean, yeah, sure, Matt Hancock could decide to get out the Tipex and erasers in the next iteration, but I think it's unlikely because it's not just LMCs. You've also got the local dental committee, the local pharmaceutical committee, and the local optometric committee. So when we talk about primary care, and you'll often hear, especially if you start to train your ear a little bit, you'll notice that NHS England never talks about general practice. It always talks about primary care. But primary care is general practice, dentistry, optometry, and community pharmacy. So if you mean general practice, always say general practice. That's a bit of a tip for you there. So GPDF's job, GPDF itself is a company limited by guarantee. It's got its own board of directors who are members. They're nominated from LMCs across Great Britain. The majority of the board of directors are GPs or have been GPs. There are some non-executive directors or NEDs, that's another TLA for you. And they've got a lot of skills or experience in other sectors, for example. So their purpose really, I guess, is to strengthen the GP voice. It's to fund interventions. It's to fund initiatives. There's been, for example, some judicial reviews around pensions pertaining to GPs. There's been a court case with Northamptonshire County Council and Northamptonshire LMC around securing payments for safeguarding reports, for example. They engage in dialogue and as I said, they top up that BMA branch of practice work. That's pretty much the remit of GPDF. And there's a number of us and various LMCs who are actually looking to see how can that scope change. Maybe there needs, where are the discussions around LMCs being the best organisations they can be? How can we ensure they're diverse? How can we ensure the LMCs represent the local profession? And there's that accountability and transparency. So maybe, that's something the GPDF could fund, almost like an association of LMCs, where they could have an online portal for a repository of sharing all the local enhanced services across the country. Because if I'm going to be negotiating a shared care agreement of the prescribing of ADHD meds or the maintenance prescribing around SSRIs in under 18s, I might want to look and see what's been written elsewhere, what things have been covered off. I don't want to reinvent the wheel all the time. Or, local enhanced services around, the prescribing of DOACs, for example, is a good example. So there's that 5% of their collective levy from LMCs funds the GPDF. LMCs. What's the next slide? Oh, that's GP contracts. So sticking with LMCs. So the LMC, we're statutory bodies, but we're not. Well, we're a body in statute rather than a statutory body, and a body named in statute means you are independent, whereas a statutory body has other pieces of legislation that it must follow. So we are recognised by successive NHS acts as the professional organisation that represents individual GPs as in the performers list and performance processes, and that's really important. We'll come on to that in a bit. But also practices as a whole to the commissioning organisation. And the NHS Act in 1999 went a bit further, and it extended the LMC remit and role to include representation of all GPs, irrespective of their contractual status. So to include locums and trainees and salaried doctors and so on. So we cover the whole profession. Now, so the LMC represents a kind of unified GP voice to any external organisation or agency that it needs to, be that a CCG, be it NHS England, be it a local authority, a local constabulary, a local school, or whatever. So yeah, we are very much around professionalisation of general practice. We've got a lot of experience in governance and in negotiation, contracting, knowledge, and so on. And so we've evolved a huge amount from those early days around the kitchen table around 1911. We're quite big organisations now. So yeah. So I guess what's going to be helpful now is to better understand, actually, when we're doing that sort of work and we're looking after GPs and their contracts, what are those contracts? How does GP contracting work? What do all those things mean? Because no one ever really teaches anything. So as I said, at the moment we've got CCGs as the commissioner, and that originally in the 2012 Health and Social Care Act, it was around NHS England, and then slowly they've delegated it down to CCGs, and now everywhere it's a CCG that holds the contract with a GP practice. Before CCGs, it was primary care trusts, PCTs, and before PCTs it was SHAs and DHAs, strategic and district health authorities, and before then, well, it's basically one never-ending circle where they reinvent the same thing every few years along the way. So yes, we've got the national contract that is negotiated by GPC and locally implemented by the CCG. We've got local contracts that are negotiated by the LMC with the CCG, with rules attached. And the CCG has its discretionary budget and its delegated budget. And those local contracts can be LESs, the local enhanced service, or they can be SLAs, a service level agreement. Yeah, so that brings me to those rules I mentioned around the LES monies and the PMS rebalancing monies. You're like, well, what's PMS? What's rebalancing money? So let's go a little bit about GP contracts. So there are three types of GP contract. This is a contract between a commissioner and a practice, and it can be GMS, PMS, or APMS. So every individual or partnership of GPs must hold an NHS GP contract to run an NHS commissioned general practice service. And they set out the mandatory requirements and services that all GP surgeries have to offer, as well as making provisions for other types of services if they choose to. And so, yes, we've got GMS, PMS, and APMS. So the GMS is the national standard GP contract. It's about 70% of all practices are GMS. It's negotiated nationally every year between NHS England and the GPC. Its funding depends upon its practice population in a calculation called the Cahill formula. And that population funding formula is actually called something called the global sum, which some of you may well have heard of, often abbreviated to GS. And the global sum allocation formula, it's paid. It's kind of like a minimum. Historically, there was a minimum amount of funding that was seen as being essential for the provision of services, and that was kind of locked in as something called the minimum practice income guarantee, and that's been phased out. And how it's been phased out is how it's been called the correction factor, and that goes down each year for those practices that have it. But for most practices, that's now finished, and they're just paid through their global sum. And the formula kind of like takes an estimate of what the practice workload would be based upon their demographic. It takes into account many factors such as drivers of workload and unavoidable costs. And so it might break it down into, for example, patient age and patient sex. So, you know, a little boy won't cost you much money. He's not going to present very often, whereas an old lady might present very frequently because she's got lots of complex multi-morbid long-term conditions that require a lot of intervention. You've also got the additional needs of patients. So using a health survey for England with data from 1998 to 2000, so it's pretty out of date, formula takes into account standardized, limited, long-standing illness and standardized mortality ratios for people aged under 65. And also it takes into account list turnover. So patients in their first year of registration, it estimates are going to have more consultations than others. So it adjusts for that. So if a practice closes, a very little practice, let's say, and the patients are dispersed amongst local practices, when you register, you get paid the global sum for that patient for the year, but you also get paid 46% of the global sum on top to accommodate for what they imagine to be the increased work required in terms of note summarising, investigations, taking over that care and establishing that relationship with that patient. And there are the unavoidable costs. So staff market forces, the cost of living in that postcode area, the geographical variation in staff costs, and the rurality and the impact of rurality, which is modelled using HMRC information. Against practice expenses, GP expenses, and other factors. And so each adjustment to the formula kind of generates a separate practice index where you get a practice score adjusted to the national average. And the national average is then weighted. So the average is 1.00. And so you might have a practice that Carhill is 86. So if the average practice is 1, in other words, £1 per, then they get 86 pence in every pound, which is why at some commissioning meetings you might see that you've got 11,000 patients, but you're only paid for 9,864. So that is calculated quarterly on the first date of each quarter. So your weighted population. So there are winners and losers. So if you've got a particularly deprived population, then your Carhill might be 1.24. So you get 1.24 times the global sum for your population. There are winners and there are losers. And when in the bell curve, it's those extremes that need to be catered for with add-ons to try and help bring them back into the middle. So there's a lot of debate around Carhill and how it needs to be looked at again, especially for those practices that lose out. And there's some atypical population funding that can help correct that gap. But I think a lot of things have changed. There's a lot fewer dispensing practices now than there were. Rurality indices have changed. Long-term health conditions have changed. Demand from patients has changed. So there's very much a feeling that we're looking at data based from 1998 to 2000, 20 years out of date. Look at what's changed in child practice in the past 20 years. It is incomparable. So this has got to be addressed. And yet the government keeps putting it on the too difficult pile. And I think to a certain extent, I can see why GPC, it's a bit of a difficult nettle to grasp, because there'll always be new losers and new winners. You're never going to please everybody just by the very nature of the standard deviation curve. So that's the GMS contract. The PMS contract was brought in before the new GMS contract in 2004. It's another form of a core contract, but it's negotiated and agreed locally, which gives the local commissioner an alternative route to be a bit more flexible around what it wants to commission, depending upon that population. It can tailor its requirements, if you like, to local need whilst keeping within national guidelines and national legislation. The PMS contract is actually being phased out. It's quite expensive for what it is. 15%-ish practices hold one, and often you'll find that those who have one have quite an atypical population. They might have a very high turnover of an immigrant population, or people who do not have English as a first language, or have a very significant traveller Roma population, for example, or it might be around recent children, for example, in a very specific area, or a new build town. So there's lots of different needs to it. And when those contract reviews over the past 10 years have reverted from PMS to GMS, money has been taken out to then even up the GMS load, and that money is what sits in the local budget that is negotiated with the LMC to put things in place, such as your local LESs around minor injury, around, DVT management, or, Dopplers or whatever. And then you've got the APMS. By the way, it stands for, so it's General Medical Services is GMS. PMS is Personal Medical Services, and an APMS is Alternative Provider Medical Services contract. And the APMS contract is the only new contract that can be created as of April 2015, and it is a commercial time limited contract. Historically, maximum of 5 years, but now it's going on a bit longer, and I'll explain why. Whereas the GMS contract and the PMS contract are contracts held in perpetuity. They only end when the provider chooses to terminate them. So it's interesting that when you've got GPs who can't provide anymore the services, they can't make the numbers work, that a GMS contract will be terminated, but it's going to have to be an APMS contract that then goes in its place. The only way you can hand over a GMS contract is if you get partners merging onto it in a takeover and they take it with them. But if the numbers aren't working for that practice, very often you'll find that providers don't want to merge, and they are happy for the contract to be terminated because they would rather have a more financially advantageous contract offered in an APMS format, even though it doesn't give them the perpetuity and it gives them time limited. The funding per patient can be significantly more. So you might think, well, that's insane. Why are we, spaffing loads of money on an APMS contract when it's not giving us value for money? Well, you are quite right. General practice offers incredible efficiencies, and I think this lesson is slowly being learnt, because what we're seeing now is much more guidance from NHS England coming out around longer APMS practices contracts, be it 7+3, or 5+5, or in some cases even 20-year contracts. Because when you've got a 5-year contract, it's difficult to recruit and retain really good staff, because they're always going to be thinking, well, hang on, I might be stupid to somebody else in 2.5 years' time. Where's my certainty? Where's my role going to be? Where's my autonomy? Where's my influence in this organisation? If you're working for, say, a big multinational provider comes in, or Virgin have taken some APMS contracts, for example. So it's a winner and a loser. And the APMS contract offers the commissioner the greatest possible flexibility. It might say you've got to open from 8 till 8, 7 days a week, including Christmas Day, as like a walk-in centre element. It might say, okay, so you've got the vaccinations and immunisations part of QOF, but actually locally we've got really poor vaccination coverage. We want your childhood IMS targets to be this much more than QOF, and you have to deliver that as part of your contract. So it's very much tailored to what the commissioner's needs are rather than the provider. It is very expensive. You can also use it to commission different types of general practice other than kind of outside the norm. So, you could, a social enterprise. So, for example, providing specific general practice services to homeless patients in an area, or asylum seekers in an area, would be commissioned via an APMS with very specific health outcomes attached to the needs of that population. Okay. As of a couple of years ago, only about 2% of practices hold an APMS contract. But as of today, I should think you could easily double that, if not more, probably be over 5% now. So in terms of what's in a GP contract, so we've talked about the DES, the Direct Enhanced Service. That's a national bolt-on to the contract, like flu, like the Special Allocation Scheme, like the PCN DES. And you've got the LESs, the Local Enhanced Services, that are the things negotiated with the local medical committee around the little extra bits you do. And you've got just a simple enhanced service, which we haven't seen for years. Then suddenly one was put on us in December with the COVID vaccination enhanced service. That's
probably the biggest enhanced service we've had to deal with in years as well.
Funny that.
Talk about way of bringing them back, yeah. So for those that haven't picked it up, we're talking about the vaccination enhanced service, the one that we're all currently jumping around and delivering, probably the most amazing vaccination program ever seen in this country. But yeah, that was effectively an enhanced service. It wasn't a DES, it wasn't a LES, it was an enhanced service.
And you might think, well, who cares? It's just words. Well, actually, if it's a DES, then the finances around it and the terms around it are locked in to something called the SFE, which is the Statement of Financial Entitlements, which would mean the government couldn't chop and change all the things that it is doing with the enhanced service. So that's why I think a lot of us in LMC land were disappointed that this wasn't going to be a DES, because we wanted to give practices that level of financial certainty around what they were dealing with. Whilst absolutely you can appreciate the government needed a lot of flexibility in terms of the flow and the types of vaccinations and you name it, it has meant that life has not been easy for general practice. And I would also argue that we have had the worst of both worlds in having to cater for the ultra low temperature conditions and being asked to have separate locations and being told it can't be delivered from practice. It has added bureaucracy and difficulties, but we have smashed it out the park.
Absolutely.
So, but that I think is due to the blood, sweat, and tears of GPs, rather than any help from anyone else. But there you go. And OOH is out of hours, which is your local out of hours cooperative that manages your patient care between 6:30 in the evening and 8 o'clock the next morning, and at weekends. And QOF, the Quality and Outcomes Framework, which is the points-based quality areas around the national contract, on the national GMS contract. So what else can we do? So we know about essential services. They're what's in the GMS contract, and out of hours we know is your local out of hour area. That they assume they provide that by default, but practices can opt out. You do get some practices that opt out of their out of hours supplement, and they choose to provide their own out of hours care to their patients. Not all, a significant minority, but some do. And then you've got additional services. So like minor surgery, for example, and you've got the enhanced services that we've spoken about. And then you've got the locally commissioned services, which are those ones that might be commissioned from non-NHS organisations, such as local authority public health departments, mental health support programmes, homeless programmes, and so on. And the QOF, the Quality and Outcomes Framework, those payments account for about 10% of a practice's income. So that's what's interesting about this invitation to practices about whether or not they want to embark on phase 2 of the COVID vaccination programme, because from the 1st of April, from tomorrow, there's still that appreciation that there's going to be an element of business as usual and practices needing to hit their QOF targets in quarter 1 and quarter 2, as well as offering phase 2. So that's pretty hard, because if you think about the acute sector, they've got a recovery programme for the next 2 to 5 years and they're being funded 6.6 billion towards doing that. We were given a sweetener of 120 million to take part in phase 2. So it feels a bit David and Goliath, doesn't it?
Absolutely.
The overwhelming majority of practices take part in QOF. QOF has been a huge success. The framework covers all different areas of clinical domains, prescribing safety, asthma, hypertension, ill health prevention activities, and so on. And each of them attract a certain number of points. At the end of the financial year, the practice gets an amount of money based on those points achieved within its QOF framework. And if we move on, we've also, just before we go on to those extra little bits there that we've also got premises payments. So if a practice is leasing its premises, then it's generally its rent is reimbursed in full in arrears. If a partnership owns the premises, then its mortgage payments are reimbursed, but most practice premises are leased. And some practices might sublet rooms to other providers, for example, a community health trust and so on. But there are quite a lot of rules around what a practice can use its building for, which will affect its reimbursement. And then you've got other administered payments that kind of come through NHS England that go to the CCG. So, and those are called primary care organisation, PCO administered payments. And they might be, for example, locum allowance, parental or sickness reimbursements, or retainer scheme payments. And they go through the NHS England into the CCG and into practices. And there's some really good stuff on the King's Fund website that helps explain those things in more detail. So really briefly, because I know how are we doing for time?
43.
Oh, okay. So I probably ought to wrap up shortly, shouldn't I?
Let's go for it.
So partners will basically make money from what remains after all the other expenditure has been accounted for that we've talked about. And that personal income is used to then pay their pension contributions, their tax, their indemnity, GMC and other subscriptions and so on. And some partners might choose to invest the remaining money into the practice. But it's important to note that, partners in practice are also personally liable for any losses made by the practice as well. So when the good times are good, they're very good. And when the good times are bad, they can be very bad. So GP partners aren't just clinicians, they're also business owners and employers, and that comes with a number of challenges. So the need to manage and optimize complicated income streams and personal liability for financial risks and HR and so on. And that's another area that the LMC can help support practices in. But equally, it can be incredibly attractive. You've got autonomy, you've got leadership, innovation, you can embark on research and development, you can address your population needs, and it can be a really, truly wonderful thing being a partner. It can really scratch that itch, especially if you're very much a doer. So I can absolutely recommend it. So the other thing that the GP contract has got is these national bolt-ons. We've spoken briefly about the PCN DES, the Primary Care Network DES, and that was introduced as part of a 5-year contract by NHS England in 2019. Tomorrow is the start of year 3 out of 5 years, and each PCN has got its member practices in a given population area that's around about 45,000 patients, and one of those GPs doesn't have to be a GP, but commonly one of those GPs that leads that PCN is called the clinical director or the CD. And there's monies that come through the government to fund additional workforce, additional roles, and that's what the really unfortunate acronym of ARSE comes from, which was pointed out to people at the time. I was there saying, you want to call it ARSE, which is the Additional Roles Reimbursement Scheme. And all of this is all founded and underpinned by the LTP, the NHS Long-Term Plan. And this is around shifting resources and care from the acute, expensive trusts that we can't afford in hospital into the community. And that original planning was around Vanguard sites in 2016, and then it became Sustainable and Transformation Partnerships, STPs, and now we're seeing them progress into these integrated care systems. We've got a draft white paper out. This is probably going to come to fruition a year from now, and the ICPs are going to be what's happening integrated care at partnerships at a place level. So you might have the system is the whole patch, and the place might be the north and the south of it, or the east and the west of it, in old CCG footprints. And the idea of this is to pool all of the money together in all the trusts and the local authority and primary care and secondary care and tertiary care, and to manage the deficit. So underpinning this is all about saving money, and how can we reinvest this in patients better, which is very interesting, but is now the time to enforce a whole organisation change and restructuring, especially when there's the question mark over resources and finances in the wake of the pandemic. So that is very much a whistle-stop tour. Maybe another time I could do a session on performance processes that articulates actually what the performers list is. If you have a problem locally and a complaint goes to NHS England and you're invited to go to be heard at the PAG, what the PAG is, the Performers Advisory Group, and actually how that sits in local performance processes with national ones of the GMC, just to try and, I think knowledge is power. And I think when you understand these processes, they feel a bit less scary. So I'd be very happy to come back another time and talk around those as well.
Awesome. And you're right, there's lots of other acronyms that I know you've mentioned a few of them there about various different performance assessments and all that kind of stuff. I mean, definitely things like, obviously GMC, I'm guessing most people have heard of, but MPTS, maybe not, the MDO, definitely worthwhile another session and things. I guess what I would love to know, so first of all, thank you, Katie. That was an amazing introduction, not only to the history of general practice, but also the structures that underpin how general practice functions. I think it helps to clarify to many people, the difference of, what is the GPC versus what the RCGP does, and common misconceptions many people have. I've sat on the RCGP where many people said, oh, you need to be sorting out our contract. And obviously, that's not the RCGP's job. They'd be massively overextending if they sort that out. But they have helped. I think that's probably the best way to describe it.
I think we get the best as a profession. We get the best when the GPC and the college work in synchronicity. There's no one wins when we're locked against each other. Agreed. I completely agree.
Cool. So I guess we have had some various questions that have come through already, and this is the opportunity that anybody that's watching us can ask any questions. I know we've had one already, so that's kind of come from Ed. So Ed, I know very well. I think you may have come across him before. But so one issue he said about was about that populations to be consulting more, using up obviously a lot more GP time. There may not be a medical need, so that's not really factored into the Cahill formula. Is GP time actually factored into the Cahill to account for this or not?
No, it's not. It's not. And I think that's a really good point that Ed makes, actually. If you think back to actually how GP time is funded, it actually goes back to really old contracts, something called the Red Book contract, which preceded the new GMS contract in 2004. And the Red Book contract came out of negotiations in 1966, which is when GPs last did industrial action on the streets. And that is around, they generally suppose that a patient's going to need 2 home visits in a patient's lifetime, and one of them is going to be to certify the death. And they assume that a patient might present, 1.6 times per annum, when we know the average patient is now, we've seen an exponential rise over the past 10 years alone. That 5 years ago, they were presenting 6.7 times per annum. Now I think something like 8.9. It's ridiculous. But how that could potentially change with how we now are working in different triage systems and with remote work, I think it's going to be really interesting to see how that pans out. We're in a real state of flux at the moment, and I think we have to be super careful not to keep too much remote, otherwise we're going to lose our USP. That's of course the other TLA, our unique selling point as a profession in having that contact. And we don't yet really have a feel for the edges of the problem about how much pathology has been missed in the past 12 months. And I think we're going to need to take what's been really good and what has worked for us in the past 12 months, which means we're not going to be free at the point of patient demand. There needs to be a check there. Actually, well, let's intervene here. Let's see what you need. But also, something that I'm really conscious of, and I'm sure you are where you practice as well, is that the potential risk of widening health inequalities through the use of digital first, because it's all very well to invest in these marvelous apps that assist the patient to be able to report their own telemetry and take control of their long-term condition. That's great. That's great when you've got, intelligent, affluent patients, but who speak the language easily and have access to tools and smartphones at their disposal. But if they're newly arrived in the UK, if there are language barriers, if there are technology or age barriers, or discriminating against LD patients, then that's actually going to perpetuate the problem and actually exacerbate the divide. And so I think we need to think a bit more cleverly around when we're purchasing these digital tools, when commissioners are, for use around practices, we need to really scrutinise and discriminate between where's the offer sitting here, who's truly benefiting from it. Because for practices to benefit, for the population health to benefit, it needs to be meaningful to the patients who are going to be using them. And it's no good if it's only going to, really benefit the most affluent, healthy 5 to 10%.
Absolutely agree. And I think there's also that, like you said, that's that wider discussion across the profession that's currently happening. I mean, I've seen it on Twitter and all the social media for the past few days of this whole comparison between, total triage, digital first versus we want to go back to face-to-face, seeing everybody in our room straight away, whether that's patient or clinician driven, doesn't really seem to matter. But actually, the future is a happy medium between the two. That's what it has to be, because we can't go all the way this side to tech. We can't go all the way this side just to face and things. We've seen the challenges that provides. So we have to find a way of making that work. And absolutely, the funding has to make that work, because if it doesn't, we're going to see the end of general practice. Although we've been hearing about that for several years now, haven't we?
It's always the end of general practice. Always. There's always an app for it, or a Babylon's the end. Well, look at Babylon. Where are Babylon now? So it's interesting. Yeah. Okay. Always expect the unexpected.
Absolutely. I know we've had a couple more questions that have come through before the session started, and I guess these were ones I wanted to ask a bit. Feel free to say that these may not be things that you can't specifically speak to, because I know they're quite specific ones around the GPC and things. When the whole kind of PCN-DES kind of kicked off and that kind of stuff, there was lots of questions and challenge about the process of how decisions were made, particularly within the GPC and that kind of stuff. And I don't want to talk necessarily about those, But can you give us a rough idea of how the kind of process of changing things in general practice works? Because I know there's obviously the LMC conference, and there's obviously the GPCs themselves and the representation for the reps. Can you just give us a brief kind of idea of how that whole system works so people can understand how change happens?
Yeah, sure. So I think there's always the delicate balance when you've got a branch of practice committee and you're partaking in national negotiations of the need for confidentiality. And we have had some leaks from GPC, which has not been helpful, and which has made negotiations quite fraught on both sides. And leaks have been happening from both sides, to be honest. And I think in today's day and age, I think we have to be, maybe, dare I say, a bit more cognizant and a bit more realistic about what's actually achievable, and maybe sharing more information sooner and bringing people with you in that more consensual style of leadership is going to be what's needed. And that's true for both parties. There is, with GPC, there is the conference of LMCs where each LMC sends a delegation, and you've got the England conference and the devolved nation conferences, and also the UK conference. It's the UK conference that's like the standing conference that has the kind of authority to have various elections and roles and the rest of it. And that is pretty much the body politic of general practice. That's where you can bring motions, and you decide what they're on, and you decide what you believe and what you call for and what you seek to implement, or what you seek to mandate GPC to do, or what you mandate GPC to ask for from NHS England, or the government. And if that's passed, then that does kind of become one of the areas of policy for those policy groups to take forward and to enact. And it can be really helpful and really great to see a passion or a problem that you've come up against. So as a sessional GP, I really had a big challenge in trying to get evidence to renew my letters of competence in my IUCD and SDI insertion certificates for the need. And so I put a motion to conference, it got passed, and I was then asked to work with the faculty of reproductive and sexual healthcare to actually change some of those requirements to make it easier for sessional GPs to demonstrate what they were doing. And there was a really good motion that came from my colleague Gaurav in Kent around the unconscious and conscious bias in performance advisory groups and performance processes within NHS England that are punitive to GPs, around the name of the GP, and if it's like a non-Anglo-Saxon name, and some of those inherent biases and thought processes that could potentially take place. And so we're currently working with NHS England and in performance advisory processes to look at removing the name of the practitioner from those inquiries to see how people's judgment changes and so on. So there's some really cool stuff that you can enact. And I think, the conference is not backwards in coming forwards to GPC in being quite strong in terms of when it's not happy with a direction of travel. I think what's true in terms of PCNs, it's a very mixed bag. There was recently a survey that did attract some criticism into how it was worded. And whilst the result was quite clear in terms of the mandate, the actual volume of response and people who bothered to engage was pretty poor. So that didn't really satisfy either party. Could it have been done better? Yeah, I think it probably could. And I say that because it led to the special conference, which was just over a year ago, just before lockdown, actually. And you really heard the strength of feeling and concern from LMCs around the country, around the PCN Des, and very much who is this for? And I think what LMCs keep on trying to reiterate is the raison d'etre for the PCN, for the primary care network, was to provide workforce and provide resources for general practice teams. And you might say, well, why aren't GPs and why aren't nurses in the additional roles? And the reason was there aren't enough of them about. If there are a surplus, then we'll have them, but there aren't. So we're going to give you a physiotherapist, we're going to give you a pharmacist. But then how you share them, where the liability of employment sits, and so on, other bigger questions that perhaps needed more time to triangulate. But at the flip side, also at the same time, we had the indemnity issues resolved. And sometimes it's a quid pro quo, and what are you going to take and what are you going to give in any negotiation for it to be acceptable enough to both sides. So yeah, but I'm always very much of the spirit of more transparency, more accountability, and bringing your constituents with you. There's no benefit to hiding things or surprising people, because they're going to be suspicious and they're not going to be happy, and this is going to change lives, you know. So yeah, it's a tricky balance. I don't envy Richard and the executive team their job. It's much easier to be me and just sit and complain on the sidelines.
And I guess talking about that job, one theme that has definitely been there for several years, and I'm not talking about PCNs and the slight declaration also with PCN CD, but in terms of that has been PSCE and the absolute debacle that I think general practice has felt that the contract with PSCE has been.
Or PCSE even, Primary Care Support England.
Yes, PCSE. Yeah. Sorry, I'm getting
primary. Yeah,
myself.
Primary Care Support England is subcontracted to an organisation called Capita that runs those sorts of commissioning support units in the background. And around our pension contributions, around performers list management. And you're absolutely right. We all could see it was going to be a nightmare when you're losing all those really great members of staff who've known people and processes for so long, and what knowledge was lost in that whole scale reorganisation. It's incredibly regrettable. But that's in the gift of NHS England. That's got nothing to do with GPC in terms of how it was done and when it was done and why it was done, because that's all the auspices of NHS England. But yeah, it's a source of enormous regret and frustration, and continues to be so.
Absolutely. But I guess one of the criticisms that does seem to be levied at the GPC in particular is in terms of the ongoing negotiations with how PSCE and everything else functions. I guess, do you see that changing anytime soon? Because it hasn't done, despite us having the challenges for near 3-4 years now. And I think what you've got to stand back and have a look at is the fact that the government's got an even greater mandate since the December 19 general election. You know, it increased its majority, which suggests the population at large is happy to plough ahead with the direction of travel, and that's what you're working with here. You're working with politicians who represent their party and their processes that they've decided to go with. But you're right. I think it is a challenge. We have seen some changes, though. The way the performers list is now online is better. The transparency of being able to get the forms is easier. I think there needs to be better education and training at a GP trainee level from local LMCs around understanding the importance of the performers list and your membership of it, and what you need to do before you finish your CCT, you know, to ensure you don't fall off it, or when you take, you know, parental leave or sickness absence and the rest of it. So there's things that we could do better. And the same is true with NHS Digital. When you're on maternity leave and you come back and your NHS account's been deleted, you know, things like that. Those allowances sit at a local level and at a practice level, but sometimes there isn't the expertise and the skill because there hasn't been the training put in place, because it's not like picking up the phone to speak to Carol at the local commissioning support unit who knows what's going on. You put on an automated, anonymised inbox to PCSE, and you don't get a response for no matter how many days. And it's a bit like how the world is changing, isn't it? It's the same with, you know, trying to speak to your coroner's office. Now it's got to be through online and the rest of it. And I suppose patients feel the same. You could call up and go and see lovely Dr. Smith, and now you've got to put in an e-consult request and go through a triage of 50 questions to say that your arm isn't hanging off. So it's the way of the world to a certain extent, and that's not an excuse at all. I mean, I'm quite a fierce critic of GPC, even though I sit on it, because I want it to be the best it can possibly be, because we don't have anything else, and we have to do the best we can, because actually and we'll know we're doing okay when we start to see the rate of attrition start to level off from GPs and more people want to come into the profession. But at the moment, it's also compounded by that lack of patient access and getting the balance right between remote work and face-to-face. Because I can imagine for a lot of trainees, they're like, well, how am I going to get my clinical skills? How can I know where the needle in the haystack is if I've never seen this haystack before in my life? So there's a lot of work to do, And so we need the best GPC we can have to get the job done. And so my final question, and I'm aware we've run slightly over our planned time, but I think this is an important one as well. So imagine I was to jump in my time machine, go back, 15 years. I'm now an idealistic young GP, just fresh out the block, wanting to change the world. How do I do it? Where do I go? If I want to actually change my local area and I want to change my national area, what would you suggest is the best way for me to do that?
I would certainly get on your LMC. I would stand for election, go and speak to your local LMC office, drop them a line, have a chat with them about things. They'll be really enthusiastic. They should be really enthusiastic about somebody who's newly qualified and wanting to do more stuff and understand how things go, get involved in some local education programs and initiatives. There's loads more out there now than there ever has been. And I think listening to, blogs and stuff like your own is really key. And get onto medical Twitter, get onto GP Facebook, start to listen and learn. There's huge amounts that you won't have been prepared or taught in your VTS that opened up before you, and you think, wow. So to work somewhere that you feel safe and that you feel mentored and that you feel secure in your ability to learn and to expand your knowledge base. And I think, it depends upon what line you want to go down. The college is there around education and quality and public health messaging. And you've got, if you want a slightly more political angle, then you can go down, the conference route from your LMC and maybe stand and get elected onto GPC. But if you really want to get things changed, you could also, start to become a clinical lead in your CCG. But just as long as you must always stand back and remember who's paying your wages and what are you doing this for? Are you doing this for yourself to earn money? Are you doing this because you actually want to make a change? And what change do you want to make? You can't change everything yourself. So choose one little area and then find your allies and then always have a conversation. And remember that a negotiation isn't somebody winning. A negotiation, a successful negotiation, is two parties reaching a mutually acceptable middle ground. It's all about compromise and what you're prepared to compromise. And if you look back to the GMS contract of 2004 and how GPC won and beat the government, well, the Daily Mail and NHS England have been making us pay the price for that for the past, 15 years. So that wasn't a successful negotiation, was it? So think about what's achievable and follow your interests. If it doesn't spark joy inside you, I sound a bit like, a nonsense person.
Marie Kondo, yeah.
A bit Marie Kondo, but if it doesn't spark joy, then life's too short. Go and find something that does, There'll be something, because general practice is so broad and all-encompassing. There will be something in there for you to find your ikigai.
Awesome. I think on that note is a great place for us to finish this stream. We've had some amazing comments, so particularly from Ed, thank you, really comprehensive presentation, and I absolutely agree with that. I personally think this episode, absolutely out there for GP trainees, and to be fair, many of my GP colleagues, just as an educational module, to try and update yourself on what general practice is like and stuff. And you never know, I may even give you a certificate at the end of it if you do get to this point and stuff. So there you go, even though you don't need it for your appraisal anymore.
Absolutely.
Thank you very much, Katie, for your time. I've really appreciated it. I've learned loads. I thought I knew loads, and actually you've taught me even more. So that's absolutely awesome for me, and absolutely for our colleagues and stuff out there. Yeah, thank you very much. And I know you do some amazing work out there, particularly on the LMC front and the conference and things. So thank you.
My pleasure. Thanks ever so much.
As always, EGP learners, if you do have any comments or questions, feel free to whack them down below, stick them in the comments section and stuff. Definitely like it if you like this content. And if you do want us to bring Katie back to talk about all the performance stuff and things like that, absolutely let me know. I know she'd be more than happy to do so. I'd be more than happy to have her back on the channel and things. And we'll arrange that for you as quickly and as effectively as we can. And as always, EGP Learning is here to help save you and your patients time by taking hands in your primary care and learning. We'll catch you in the next episode. Ta-ra.